So the topic I've been asked to speak is immunosuppression drug
Yeah,
monitoring.
we
I want to
heard
put a
all that.
bracket around that.
We heard all that. We heard the part about the your favorite slide and how you,
Did you
yeah,
hear about
yeah.
monitoring immune status?
No, you can start from here.
Okay, so the concept is drug levels do not indicate the level of immune status in a patient. A simple example is 5 patients having a TAC level of 8. One may be over immunosuppressed and other guy may have rejection. One may be overtly septic, develop sepsis or prone to sepsis, and one guy may be adequately immunosuppressed. So a particular level does not reflect the immune status of the patient, and the assays which have been touted to measure the immune status, I've just listed them down here. Dr. Prasoon Jalal did talk about some cell-free DNAs and biomarkers. Cytokines, chemokines have been used, not very successfully. A lot more data is required. T-cell activation assays came with a lot of bang around 10 years back, but as of now, they're not commercially available. What they do is they look at proliferation of T-cells in response to specific antigens. And they measure ATP usage in the T-cell. The Silex assay actually measures the ATP usage. Luminex sees the response and the T-cell proliferation. Then you have virus-specific T-cells. That concept also is there, but none of them are commercially available. We are actually looking forward to have some assay which can tell us the immune status so as to modulate the immunosuppression rather than the drug levels itself. Dr. Gupta talked about CMV DNA as a marker of immunosuppression. Now that's a very insensitive marker, but what has been used, especially in kidney literature, is TOC tenovirus. Now this is a ubiquitous virus. It's it's a non-pathogenic virus, and the levels do go up. It is present in almost everybody. And the levels do go up with over immunosuppression. There is some data in the renal transplant, but not in liver. But that's one candidate. But this is not what we are doing. So I'll move on to what we do. This is a conceptual thing. So let's look at the approach to immunosuppression. We have two phases of immunosuppression. We have induction phase and we have maintenance agents. Antibody induction and hydrosteroids are used for induction phase. Hydrosteroids are used across board. We did hear a few speakers talk about lower dose of steroids in the intraoperative phase. But antibody induction is basically not used these days mostly. The only role it has is in the renal sparing protocols. Somebody who has a kidney disease, somebody who has a hepatorenal syndrome or borderline kidney functions, we often use IL-2 receptor antagonist, specifically basiliximab. And that's probably the only role of antibody induction. If you want to monitor antibody induction, there are no levels to monitor here. So once you give a specific antibody, the target engagement is within 12 hours. So by the end of 12 hours, the drug levels in the blood will be 0. So you have surrogate markers. The surrogate markers to measure immunosuppression in these patients are TLC, lymphocyte counts, and specifically CD3 counts, which is used for ATG. So that's how you can surrogate measure immunosuppression, but you cannot measure levels in antibody induction. Let's come back to the core of the talk, the maintenance immunosuppression. You have mycophenolate, you have steroids, you have CNIs, you have mTORs. Mycophenolic acid assay was commercially available in India, I think till 2017. Dr. Lal's Path Lab used to do it, but they discontinued for two reasons. Literature came up that the relationship between levels of mycophenolic acid and the immunosuppression status, they don't correlate well. Secondly, it was not even predicting the adverse effects. So if somebody has a higher mycophenolic acid level, it does not mean that this guy is going to have TLC depression or a bone marrow suppression. That's the reason nobody uses it. Across all organ transplant, it is not used, and it is not even available now. Steroids, we understand more steroids, more immunosuppression, but we take off steroids in most of the cases, except in autoimmune hepatitis or late acute rejections. We taper off steroids by the end of 6 months, so we don't need to monitor their levels. That brings us to tacrolimus, the core drug which we monitor day in and day out in all our transplant patients. The trend these days is tacrolimus monotherapy. We try to take off most of the patients off mycophenolate by the end of 2 years, maybe at 1.5 years. And we monitor tacrolimus early after transplant, and even some people do it late after transplant. I'll talk about that. But this is something which is important. I don't know how many of us go into the technique of measuring tacrolimus. It is very important for us to understand as clinicians, as hepatologists, as transplant surgeons. There are two techniques available. One is the liquid chromatography mass spectrometry technique, LC-MS. The other one is CLIA, the chemiluminescence immunoassay technique. The cheaper one is CLIA. The more expensive one is a solid phase HPLC liquid chromatography technique. The difference between the two we have to understand. Somebody who has a good graft function, a normal stable LFTs, the coefficient of variation between these two techniques is not much. They actually replicate each other. But somebody who has graft dysfunction, when the bilirubin is high, when the graft is not working well, there is a significant difference between these two values. The HPLC values, the chromatography values are much more reliable, they are much more accurate, and they're actually lower than the CLIA values. And that's what we should specifically look for. You're monitoring tacrolimus early after transplant. You transplant a guy who has a MELD of 25, his bilirubin on day 5 is 10. You do a chemiluminescence assay, it is likely to give you a very high levels. You should do a HPLC specifically. I don't know how many hospitals have HPLC in-house. Ours does not. So we are in-house doing only CLIA. We do ask for HPLC when we need in somebody who has a deranged liver function. So that's one thing which we need to remember. Secondly, I thought this all of us understand the trough levels, but for the sake of simplicity, I thought I'll talk about it once more. Trough level basically means the lowest level of the drug in the circulation. In case of conventional tacrolimus, we use twice a day dose. So it has to be measured before the dosage, either in the morning or in the evening, usually 12 hours. That's a gap we have. If you are using once a day tacrolimus, it should be measured again before the OD tacrolimus dose. So many times we order a tacrolimus, the nurse sends it 1 hour after the patient has taken the dose, which does not reflect the trough level. So that's something again we need to remember and take care of. How often do we monitor? That's an important thing. Now I told you early post-transplant, we should use HPLC. We at our center would measure at least twice weekly, in first week or second week, and subsequently weekly. The frequency of measuring will depend on the graft function. If the patient has stable graft, we'll keep on decreasing the frequency of measuring. It will go down to monthly in first 6 months. Subsequently, it is even less often, maybe once in 2 months. But what I want to impress upon the audience is possibly in liver transplant patients, after a few years, if you have stable graft function, we may not even need tacrolimus levels. So I often get patient queries. 3 years after transplant, absolutely normal functions, the TAC level comes as 1.2. The patient is scared. The report says the normal levels are 5 to 20. Would you like to increase tacrolimus or not? So I just reassure them, just don't worry about it. 1.2 is good with me. If the liver function the graft is normal, this patient does not have autoimmune hepatitis, this patient has no previous rejections, I'll not worry about tacrolimus levels. So how much we should monitor? I would like to ask the experts also here, the expert panel, Dr. Saigal, everybody who's around, what is their experience? Do they really do drug levels after a few years? And if they do, how often they do it? This is something again which we need to remember as a LRLT unit. Across India, LRLTs are more common than disease donor transplants. Law permits us to use only related donors. The trough concentrations required, the level of immunosuppression required in a related donor is much less. Evidence comes from twin studies. If you have a twin transplanted, you actually need no immunosuppression. The more the HLA matching, the less is the immunosuppression required. So biologically relative donors, recipients require less immunosuppression. And this has been shown very well in the A2ALL study. I'm not quoting literature here. You can go back and read this. 2 cohorts, biologically related donors and recipients, the risk of rejection was much lower. The protocol was absolutely the same. Now, this is something which actually where you need to look at monitoring drug levels. The long-term complications of post-liver transplant are actually correlate with the level of immunosuppression, level of immunosuppressive drugs. So higher TAC levels early on and even late after transplant predict all complications. Look at the complication: renal dysfunction, hypertension, hyperlipidemia, diabetes. All of them correlate with either the tacrolimus levels or the steroid dosages. We have already taken steroids off the picture. We only use it for 3 to 6 months. So CNIs are primarily responsible for most of the long-term complications, medical complications after transplant. So what do we want to do? We want to identify the patients who are at risk. We want to identify the problems early, and we want to minimize the damage before it is too much. I'm not going to teach you about renal sparing protocols. You've already heard about all these studies previously from various speakers. Dr. Rela talked about it, Dr. Dharmesh talked about it yesterday. So early everolimus with low dose tacrolimus may be the way forward for all patients who have renal dysfunction. Even for patients who have dyslipidemias, hypertensions, that may help. Dyslipidemia, it may not help, sorry, for hypertension patients. But this is something which I thought I'll draw your attention to. Out of the three maintenance drugs, tacrolimus, everolimus, and mycophenolate, the best toxicity profile, the safest drug to use is mycophenolate mofetil. And if I have to use a drug to minimize CNI, which has most harm, I would use mycophenolate. I just thought I'll give you some data on this. These are a few studies which have been published on CNI minimization from 3 months after transplant to 1 year after transplant. The moment you decrease prograph, the renal functions improve without increasing any rejection if you are continuing your mycophenolate. And that's a drug which I use for all my NASH patients. That's a drug I use for all my metabolic syndrome patients. So the tacrolimus monotherapy applies to a low risk standard patient. Low dose tacrolimus with mycophenolate applies to patients who have higher risk of either metabolic syndrome or renal dysfunction. You need to monitor their TAC levels, get them to minimum, maybe 1, 2, 3 after 6 months, and try to help these guys. And that's a protocol I follow. We follow at our unit. Early after transplant, even 8 is a higher. We generally maintain 5 to 6. We get it down to less than 5 by the end of first year. In a standard patient, we'll taper mycophenolate and shift to once daily tacrolimus if possible. We try to identify renal dysfunction and metabolic syndrome early. And in NASH patients, they also come in this category. We use eGFR instead of creatinine, and we stitch to either a low dose tacrolimus with mycophenolate or an mTOR with a very low dose tacrolimus. That's what we do. My last 2 slides, I'm sorry, I exceeded the time because the first 4 minutes, I was not making sense. You were not able to hear me, but these are important slides. This is one point where you want to monitor your levels when you are using drugs which either increase or decrease your immunosuppressants. They are drugs which are used across board. Look at this: calcium channel blockers, diltiazem, verapamil, nifedipine, commonly used for patients who have hypertension, macrolide antibiotics, all the azithromycin group antibiotics, metoclopramide, perinom, we use it so often, domperidone, pantocid DSR is almost a universal prescription, anybody who has acidity, fluconazole, voriconazole, all these drugs increase tacrolimus levels, and excessive tacrolimus levels cause more toxicity that we have seen. They may not indicate the immune status, but they indicate the adverse effects. So we have to take care of that. Similarly, we have to take care of the drugs which decrease these levels. You may precipitate rejection. Anticonvulsants are number 1 in that. Rifampicin, the ATT, and terbinafine. My summary slide, sir. Drugs level do not correlate well with level of immunosuppression in an individual patient, but may predict the adverse effects very well. Hence, CNI minimization should be attempted in all transplanted patients. Early on after transplant and in presence of graft dysfunction, prefer chromatography technique for measuring tacrolimus. In my opinion, few years after transplant, level monitoring may be redundant. It may not be required at all, especially in low-risk patients. And please identify those who develop renal dysfunction or metabolic syndrome early and try to help them. Thank you. Thank you for your patient listening.
Thank you, Manav. That was a very crisp presentation on this very important subject. I'm sure the others will have something to ask. Dr. Vasudevan?
We proceed with the other presentations and then take the questions later in the interest of time.
I mean, what we can do is, because there are not interrelated, so we can have quick answers because it will be better. I mean, just Manav, you made a comment, and I thought it was very important, the point you made, that immune suppression versus drug monitoring, which is a very good point, and I strongly appreciate you for that, because immune suppression overall is something which, as a concept, should grow further. My point to you was that you did mention that after 3-4 years, what is the need of doing a drug level if the patient is stable? So I'll tell you why I like to do it still. A, that if I do a drug level, maybe in 6 months' time, once in a while, it ensures that the patient is compliant. They sort of somehow get a hammering in their mind that we have to take this medicine because doctor is going to ask for a level at some stage. And at the back of my mind, I'm absolutely clear, as you mentioned, that if graphing is normal, I'm not too much bothered. I may not even see that level much also. But it is just, strike to that person that, yes, I have to take on this drug for indefinite period, number one. Number two, that you did make a very strong comment that higher levels in the long run are associated with a risk of higher complications. Perhaps, unknowingly, if somebody is having a stable graph function, but is unnecessarily being on, 8, 10 TAC level, which we don't know, probably it might help me to, reduce its dosages in the long run. So they're the two reasons I thought I should just share, if that makes sense.
I completely agree with your first point, sir. It does help in compliance. The second point, usually by the end of first year, you already have made sure that his levels are very low. So I'm talking about years after transplant. So you already know that you're trying to maintain a level of 2. It's unlikely that it will go up to 8 and 10 on the same dosage. But yes, your point is right. Well taken, sir.
Subhash?
Yeah, Manav, very nice talk as usual. But I have some, we've completely ignored cyclosporin, which is nowadays we find we use it quite often, because your sick patients and encephalopathy is there. And, we find that tacrolimus does cause neurotoxicity much more than the point that I was actually wanting to make was with cyclosporin, we used to use to get efficacy of C2 levels. Because C2 levels correlated with prevention of rejection, whereas C0 levels, the trough levels, correlated with toxicity. And similarly, for tacrolimus, I think the peak levels may be important to prevent rejection rather than the trough levels, which correlate with sort of adverse events.
Please.
Yeah.
So that's a very valid point you are raising, sir. Absolutely agree with you. Cyclosporin, whatever I've talked about, tacrolimus applies to cyclosporin. The concept of trough levels and peak levels, we presume, that's what I'm saying. So you cannot burden your patient with too many levels again and again. Secondly, we presume that if somebody who has a very high trough level is likely to have a very even higher peak level. Although they are not, they are independent of each other, I agree with you, but none of us does C2 levels these days. We are not using much cyclosporin. Even when we are using, we are not.
Yeah, but when they compared efficacy of tacrolimus, cyclosporin with tacrolimus, when they looked at C2 levels, then the efficacy was similar. Anyway, but that's something that we're using a lot of cyclosporin for various reasons nowadays. I think, I'm sure you do as well. It's not as a drug to be sort of completely thrown away. It has its place.
It has usages. It has its own benefits.
I mean, one use where you can get red cell aplasia with tacrolimus, and then you're forced to use cyclosporin. There's no choice.
That happens 1 in 1,000. But I agree with you. It has its own usages.
Thank you, Subhash, and thanks, Manav. I think we have to proceed for the next lecture. Thank